Hey guys, so today we will discuss about celiac disease. Now, celiac disease is a disease of global malabsorption. So, fat, protein, and carbohydrate absorption is affected, but fat is the most sensitive and specific nutrient which is affected. Now, it is also known as celiac sprue, gluten sensitive enteropathy, or non tropical sprue. Now, why it is called gluten sensitive enteropathy? Because gluten acts as an allergen in these patients, which is responsible for producing symptoms, and non-tropical sprue because findings uh, clinically and as by biopsy is similar to tropical sprue, but since it is a celiac disease condition, it is known as non-tropical sprue. Now, the important part comes with pathophysiology of this disease. So, in people who have genetic susceptibility to HLA-DQ2 or HLA-DQ8, they are more susceptible to get the celiac disease. So the pathophysiology includes consumption of gluten containing food. Now, gluten containing food is usually wheat, barley, rye, and some variety of oats which contain gluten. Now, gluten has a protein called prolamine. And prolamine has an antigen which is recognized by the immune system, that is gliadin. So now this is a diagram from Davidson. Instead of writing prolamine, they wrote gluten peptides. So now gluten peptides are taken up by the small intestinal cells. Now what happens before, since these patients have they're sensitive to gluten. So gluten binds to IgA antibodies. So here you can see that this is a gluten peptide and it binds to IgA antibodies and form an antigen antibody complex. So what happens is that these gluten peptides which bind to IgA antibodies, they will be taken up by the small intestinal cells, that is enterocytes, and they will be deamidated. Now deamidation occurs in the subepithelial layer which contains an enzyme known as TTG. TTG is tissue transglutaminase. Now, this enzyme it deamidates the peptide particles which are already bound to IgA and it undergoes deamidation. Now, these deamidated particles will be recognized by the antigen presenting cells which are positive for HLA-DQ2 or DQ8. So, here comes the role of the genetic susceptibility. Now, these particles, when they are recognized by antigen presenting cells, they will be presented to the T cells, that is CD4 positive T cells, which will in turn cause an immune reaction. So, Th1 based immune reaction and release of inflammatory cytokines like interferon alpha, interferon gamma, tumor necrosis factor alpha, and interleukin 1. So, as a result of the immune reaction, there will also be infiltration of lymphocytes within the epithelium. So, therefore, they are called as IEL, that is intraepithelial lymphocytic infiltration will happen here. So, because of the immune reaction that is occurring, manifestations of celiac disease are seen. Now, this will cause all of this immune reaction will cause villi to widen up eventually when it occurs when you keep eating gluten food. So, there will be widening, flattening of the villi, and ultimately will lead to atrophy of the villi. So this is the pathophysiology. Now, when villi will get atrophied, we know that small intestine is the organ for absorption. So absorption of fat, carbohydrate, and proteins will be affected along with a lot of vitamins and other minerals which get absorbed in the intestine. So let us see the clinical features of this disease. Now, major clinical features of a classical celiac disease is malabsorption because we saw the underlying pathology. So because of that, there will be osmotic diarrhea, there will be steatorrhea because of fat malabsorption, there will be abdominal distension and weight loss. But there are patients who present with atypical celiac disease because they show present with atypical features. Now, what are the atypical features? There will be growth and pubertal delay. As a result, there will be short stature in adults. Neuropathy will occur due to vitamin E deficiency and not because of vitamin B12. Now, why? Because vitamin B12 gets get absorbed in the distal small intestine. So only a distal small intestinal disease will call vitamin B12 deficiency, but celiac disease is a proximal small intestine disease. So therefore, it occurs due to vitamin E deficiency and not due to vitamin B12. Fracture can occur because of vitamin D and calcium deficiency. Other presentations are oral ulceration, dyspepsia, and bloating. Now, other conditions can also be seen, which are HLA-linked autoimmune disorders and many other conditions, which we will see. Now, they are usually type 1 diabetes mellitus, which is very common, thyroid disease, IgA deficiency. Why? Because we know that gluten particles were getting binded to IgA. So there will be IgA deficiency. Along with that, very important is dermatitis herpetiformis. Now, dermatitis herpetiformis are lesions which are papillovesicular in nature, and these lesions are actually due to IgA deposition in the dermoepidermal junction. Now, in the dermoepidermal junction, so where are these lesions seen? They are usually seen in elbows, back, buttocks, and the extensor aspects. So, this is very important to know about the dermatitis herpetiformis. Along with that, Down syndrome, Turner syndrome can also be seen in some cases. These are the other conditions which you can know briefly, and the table is mentioned in Davidson. Now, how do you manage a patient with celiac disease? So, for managing a patient, we should do investigations to confirm that it is celiac disease, so which includes serology and biopsy. Now, when we are doing serology, we will see elevated levels of these antibodies. But the most important one is anti-TTG antibodies, anti-tissue transglutaminase antibodies. Now, we will measure them like anti-endomycin antibodies, anti-gliadin antibodies, and all these antibodies are actually IgA antibodies. But as we know that there are some patients who can present with IgA deficiency. Now, how do we see that these antibodies are elevated? So, in those cases, we will measure IgG antibodies, which is anti-deamidated glutamine dipeptide. We know that there will be deamidated glutamine particles, deamidated gluten particles. So in those cases, we will see deamidated glutamine dipeptide, and we will measure their IgG antibody. So in case of patient who are presenting with symptoms similar to celiac disease, but in them IgA serum levels are low. So in them we must check IgG antibody, which is this one, anti-deamidated glutamine dipeptide. Then we will do biopsy. Biopsy is the gold standard, that is endoscopic small bowel biopsy. So 5 biopsy samples must be taken. 4 must be taken from second part of duodenum. 1 must be taken from duodenal bulb. And the features that we see on biopsy is villus atrophy. As I already explained why it happens, there will be crypt hyperplasia and intraepithelial lymphocytic infiltrates. So all these come under the Marsh classification. Now we see on biopsy that this is the normal mucosal epithelium. So normal villi, normal crypts are seen, and there are very less lymphocytic infiltrates, no lymphocytic infiltrates. And then here, if you see in case of celiac disease, there will be blunting of villi. They will become more or less flattened. There will be hyperplasia of the crypts. So there's villus atrophy, hyperplasia of the crypts, as well as there will be lymphocytic infiltration, which we can see here. So biopsy indicates there's celiac disease. But we must know a fact that serology is more important than biopsy to make a diagnosis. Why? Because serology is specific. And in case of biopsy, if it is present but serology is negative, then we must rule out the other causes of villus atrophy, which can be seen on endoscopic biopsy. So this is a table under Davidson which mentions all the other causes of um, villus atrophy seen on biopsy. Very important are celiac disease, tropical sprue dermatitis herpetiformis, which is one of the associations of celiac disease, lymphoma, giardiasis, and Whipple's disease, is very important to know. Now, how do we treat a patient of celiac disease? We will give them gluten-free diet, which will do most of our job. Now, majority of the patients will improve on taking a gluten-free diet, which is about 90%. But some 10% of the patients will be one who will show no improvement even after taking 1 year of gluten-free diet. Now, 1 year is mentioned under Harrison, but Davidson mentioned as 6 months. So we can go accordingly and mention and categorize these patients under refractory celiac disease. Now, refractory celiac disease is of two types, type 1 and type 2. Now, in type 1, we will see normal intraepithelial lymphocytes on biopsy. So it shows a good prognosis. Whereas in type 2, there will be abnormal expansion of the intraepithelial lymphocytes. Now, whenever there's an abnormal expansion of any cell in the body, we categorize it to be susceptible to be malignant. So now the associated malignancy is enteropathy associated T cell lymphoma. Other malignancies which could be associated with celiac diseases, small intestinal adenocarcinoma. So now this covers brief of our celiac disease and the important questions that can be